So as I talk about palliative care, I kind of want to know, because we've never met before as this group, I kind of just want to understand, because I can give you various versions of this talk, and how well does anyone feel like they really understand palliative care? And that's okay, because I can give you the I was kind of, sort of. Okay, someone stop me if it's too basic. I will tell you this. You know, the idea that we would focus on people's suffering is not a new concept in the world or in medicine, but it is a newer concept in healthcare. Right, since the beginning of cancer actually being described, right, when people talked about like bad humors, right, you talk to see the Greeks would particularly talk about these, you know, the idea that there's sort of an imbalance, and imbalance leads to cancer. Right? So since the beginning, the concept of suffering was well known in the literature, that people going through a difficult thing are going to have a difficult time, and that it's going to affect their relationships and their connection in a spiritual way to whatever their spiritual drive or energy is, that it's going to affect how they feel physically and emotionally. All that was sort of well understood. But if you look at like where healthcare's really leaned into that idea that we should fix it or do something about it or mitigate or ameliorate it is relatively new. In fact, if you look at sort of the first version of palliative care in the United States, it was hospice care. And hospice care is younger than me, and I consider myself to be relatively young. It was first developed in 1983 and brought to the United States. It actually came from the UK because the UK and the Commonwealth countries started to understand that, like, maybe we should actually do something about this. That sort of admiring the problem was not going to be good enough. Although admiring the problem was even a step forward, because there's a lot of the history of oncology where we just kind of ignored the fact that, like, the experience matters. What we focused a lot on is things like, I mean, look, if you read like The Emperor of All Maladies or other books that talk about the history of cancer, I mean, the fact that we were using nitrogen gas and a nitrogen mustard, which we still kind of do in some ways, to cure cancer was really ignoring the fact that the experience matters. Experience matters. I'm a breast oncologist, and even in the lung cancer space now, right, we are doing surgeries that are not about maximizing all ways to get to the best possible survival. We're actually balancing sort of like, what is the morbidity of that surgical intervention going to look like? And so in breast cancer, for example, the idea was, when you know people who've gone through that treatment, we used to do something called a radical mastectomy. That meant, like, holy cow, we would actually scrape down to the pectoral muscle and sometimes even take the pectoral muscle out, which meant that women could not actually like lift their arm up anymore or move this. And what we said is like, well, that's better than having cancer. That was the very like pejorative kind of obtuse way of saying like, that's what we're gonna do, what we're gonna do. And then what happens, we realize, well, what if we just don't do that? Can we still get the same outcomes? Well, yeah, just don't take the pectoral muscle. People will be fine from a survival perspective. That turned out to be true. And then as we got to the modified radical mastectomy, and then eventually just sort of a modified lumpectomy, let's just take out left lymph nodes and maybe women won't have so much significant lymphedema and can use their arm. What an amazing idea that someone can still use their arm. So this idea that there's this false choice between getting rid of it and helping people live longer, but just gonna frankly have like a crappy quality of life that you get to pick one or the other, tell me which one you want, or that we're gonna presume which one we know the person wants, are both sort of myths that I think are somewhat in the rearview mirror, but I'll give you a few reasons why I don't think that is. So hospice started in 1983 because there was this recognition that too many people were dying particularly, with a significant amount of suffering. And that suffering could be existential. I will tell you in my clinical practice, I've talked to people about all kinds of things related to what gives them meaning and purpose and hope. For some people, it's God with a big G. For some people, it's God with a little g. For some people, it's nature, it's their family, it's whatever drives them. So I've had some very in-depth conversations with people. I mean, you learn a lot about what makes someone sort of get up every day and kind of do what they do. And what we learned is that experience of death, as much as a healthcare was giving the attention to people's birth processes. Right? You might remember, like birthing used to be a certain way, and then we were like, we should make these rooms nicer, and then put like wooden floors in them, and blah, blah. Because this idea was that it only happens once for that person. The baby is only born once. To make the experience really good. For the mother and the family, that's the only one time they're going to see their son or daughter born, so make it a good thing. And then someone said, I think very insightfully, so, well, people only die once too. So why would we not pay the same amount of attention? Right. And then there was this philosophical argument that like medicine doesn't exist to do that, to help people die. And yet, as it turns out, that's exactly what happens. People do die. And the mortality rate for every human being still remains 5%. Hopefully it's a long time from now, but it's still the case. And so this was the premise by which it's so silly to think that that was the argument that had to be made. But it had to be made for something like hospice to get started. Unless you think that like Congress worked better then than it does today, and for those of you who might remember Congress in the early 80s, like it didn't, right? It didn't, okay? So what happened was the concept of hospice actually got snuck into a tax bill. That's how it had to happen. And it was because a particular senator from the Northeast had seen his mom go through hospice. So when you think about what you guys use patient advocacy, which had that, the power of the story is so important. It was the story that made hospice a reality. It was not the finances, it was not the language of the law. Because the language of the law was not bipartisan in and of itself. Because you are asking Medicare to pay for something. And if you want Medicare to pay for less things, then you're not going to afford it. And if you don't think that doctors or medical teams should be a part of the death process, you're not going to support it. Right? There's reasons why you may not want to support it. But the reality is, it was the first time ever that Medicare actually said, this is so important, we're going to mandate that this happens, and then give guidance to Medicaid. So 1983 is when that happened. We moved forward, and then finally people started to say, well, if this works for people who are dying, what about for people who are dying, who are going through a serious thing and need an extra layer of support? Who's going to provide that? And I think that there was a time where in oncology in particular, an oncologist could be maybe everything to everybody. Or maybe they thought they could be. And I'm an oncologist too. I don't think that I can be everything to everybody. But when I talk to my colleagues, there's those who will raise their hand by this point in my talk and be like, with all due respect, I can't. And I'm like, well, that's great. You are the outlier. The reality is that oncology teams are faced with so much right now. It's not that they don't want to be compassionate. Compassion just takes time, right? Compassion takes time. It's the difference between if I came up to you and said, how are you today? And you were like, it's been tough. For me to dig deep into that with you just takes time. It's not that I'm compassionate or not. If I'm not compassionate, I'll walk away. But if I am compassionate, it will take time for me to talk to you about that thing. Compassion takes time. That's true. There's no way to be fast with compassion. And so the thing was, the people started realizing that oncologists maybe want to do this, maybe have the skills to do this, many of them do, that the complexity might be low enough that this is what we can do. But there's also this humility that just has to be accepted, which is that if I'm given 15 minutes, and we're going to talk about what treatment to do, and what are the side effects going to be, and how many pre-authorizations from an insurance company, all these things, that when I ask you, hey, how are you doing? And you go, fine. Then if I'm like, well, if that's at minute 13, what do you think I'm going to do? I mean, I want to dig into that with you, but I may not be able to. But you might also say to me, like a patient said to me once, which is, it was a cancer patient, and I was prescribing opioids for pain. It was not bad. It was a good thing in this moment, okay? And she wouldn't take it. And so I brought her back, and I was like, how's the pain? She said, my pain's still 10 out of 10. I was like, oh, well, okay, go on. And I thought, mistakenly so, just to be clear, I might be very articulate. I'm an okay doctor, I'm trying to do that, okay? So I thought in that moment that I just needed to doctor more, and so I was like, okay, well, here's the side effects, it's going to help you, if it goes from 10 to 6, and this is what you're going to do, and this is what you're going to do. So I sent her back home. 2 weeks later, she comes back, because I wanted to check her out. 2 weeks later. She said, nope, it's still 10 out of 10, blah, blah, blah. And so I finally did something, I doctored less, kind of just listened, right? So instead of like telling her these things, I was like, like, what's the deal? She said, what do you mean? I said, well, what are you worried about? Just in general. Just tell me. She's like, you mean about the payments? No. Just more broadly. Like, what are you worried about? And she finally said to me what I should have asked at the very beginning. She said, you know, Dr. Kamal, God is punishing. And just paused. For what? She was with the cancer. I have the cancer because God is punishing me. That's the powerful wife you prefer. And you know, look, the skill here is to listen with curiosity and right? Like in my faith tradition, we're not telling you that's what I think is happening, but that's beside it. So she said, God's punishing me. And I said, why do you think that? She said, well, because when I was a teenager, I terminated my pregnancy. Oh, so because of that, right, so I started putting it together. And so that the pain experience for her, pain, was atonement for that sin. This is all her words, it's not my just, I'll explain this all. Oh, okay. So if that happens at minute 13, what am I supposed to do, right? And so the reality is that is an example where the complexity of the case is high, right? Because I'm not a spiritual counselor, I'm a spiritual person, and I'm not in a faith tradition, but I am not there and equipped and skilled to talk her through that. Because the reality is if you're in a hurry, you're going to see doctors do, you know, real things that I train them not to do, which is say things like, oh, no, honey, that's not what's done. Right? And people do that to try to be compassionate. I started by saying compassion takes time. People do this all the time. They just do it quickly and I think they're being helpful. When someone says to me like, you know, or they say like, I don't know why I have cancer. And I've trained a lot of physicians in my career. I'm actually older than you think. So I've trained a lot of people in my career and I've watched them communicate because that's what I evaluate on. At the end of the day, knowing what chemotherapy to give, I'm going to oversimplify it, you can look that up. So a lot of things doctors can and should do, you cannot look up. You just have to be trained. And communication is one of them. That's why I think it's super important. At the end of the day, we know, for example, that the primary reason that physicians get sued is because of communication missteps, not actually making wrong decisions. There's a rare that physicians make, like, you're supposed to do this, you did 180 research. It's really more the bedside management, that, like, RB factor. So I was watching this physician, this young physician, in a room, and this patient says, you know, I don't know what's happening. And I cringed, and I was going to try to pull the words back. It was too late. My physician in training said, well, you know, all of this happens for a reason. Oh no. Because what's on the other end of the sentence, which is, that's great, doc. What is that reason? You seem to know that it's for a reason, so tell me what that is. You seem super smart. So like, I was like, oh no, right? And she, thankfully, mercifully, was a patient of mine. I think she knew this was almost like a training moment, didn't ask that question, but it does beg the question. Because you feel like you're being helpful when you say, well, what happens for a reason? What is the reason? I don't know. I don't know that reason. I understand that question is an existential question. And this is a question that's about meaning and purpose and atonement, other these things that patients have articulated to me. But the humility is like, I don't know the reason. I don't know the reason. And by the way, that question, very rarely, when I've been asked that question, is a biology-based question. Occasionally someone will be like, how does lung cancer form? And okay, fine, I can tell you a little bit about that. But why you have it, I don't know. And so there's components of this communication that's so incredibly important that where palliative care as a field really kind of got born out of this idea that we're going to need to take time, we're going to need to have skill, and we're going to need to talk about compassion in a language that works for people, and we're going to have to be attentive to what those are, and we're going to have to be agnostic to the directions that they take, right? And so in oncology, when I wear my oncologist hat, right, I have a particular set of things that I may want this patient to do. When I wear my palliative care hat, I actually don't have particular things I want this patient. Now I'm trained in both, so maybe I might help myself with one hat versus the other. But the thing is, when I talk to a person and I say, look, I'm going to support you either way, right? And you can talk to me about things that I may not, I'm not going to bring up with my oncologist, something else I think it's really important. That sort of third space, that space where you can talk to your family and your friends, you can talk to your oncologist, you can talk to me about things you're worried about, ends up being a really important service for a lot of people, as it turned out. And so this field of palliative care was born out of this idea that some people need an extra layer of support. So what happened was what's happened in the field is I was trained as the first palliative care fellow at the Mayo Clinic in Rochester, Minnesota. The first ever one in 2009, which to me was not that long ago. And it tells you how young the field is. And by reflection, maybe how young the idea is that medical professionals with expertise could lean into these topics with you is also a relatively new thought. And so now I'm very proud to say that about 85% of all medium to large-sized hospitals in the country have palliative care services. About 2/3 of all cancer centers have them, but not necessarily in smaller places. And so it becomes one of those things where people misunderstood palliative care. Maybe you would have thought I would come here and just been talking about end-of-life care, which, as you can see, I'm not talking about that. And it gets to the sense of like, how do we appreciate just the humanity of another human being, even if they're a physician? I'll give you an example, and I want to also not just lecture at you. I want to share a few skills that I think I've found to be helpful. I heard earlier, I wouldn't plan on talking about this, but I heard earlier you guys were talking about caregivers and support and that feeling. I'm actually on a personal quest, and now that I'm in a position at ACS, a bit of on a professional quest to help people understand how to be allies to each other during cancer. I think, in my experience, I remember in taking care of my mom, it was a very isolating experience. That's not a reflection of how many friends or family members we had, but the experience in and of itself, actually, for most people, as we found in some work we've done at ACS, actually is not a relationship building experience for most people. Not all. Now, many of you may have examples where a cancer journey brought people closer together. The data would show that in 60% of people going through a cancer journey, they note that their number and depth in relationships actually went down while going through that cancer journey. Now, to me, when you look at that data, it may not be completely surprising because for a lot of people, many of their relationships are, let's say, in the workplace, and so now they're not going to work or participating in work as much anymore. Maybe for others, because of infection risks, that they would get a lot of their social interaction by going to church or synagogue, and now they're not physically going, so we feel a little bit more distant, right? Those are real things. And yet, when we've looked at the data, they're not all born in those real things, not all of them. And I was thinking about this. My wife's an ICU physician at UNC, and so we were talking about what kind of makes our job hard. I said, well, my 9 to 5 is hard. Don't get me wrong, but I kind of know how to do it, I think. But it's at 5:01. If my neighbor, I'm an oncologist, were to text me, "Hey, just got diagnosed with cancer. This is really right." I was like, I gotta do this professionally, and I gotta talk about this. I can tell you right now, I wouldn't exactly know what to text. Not in a FASCO. I would type it, and then I would edit it, and I would show it to my wife and be like, this. Right, because what you're doing is trying to walk this fine line between not being nosy, but demonstrating care and concern, offering help, but not trying to be overbearing. You're kind of walking this line. And it was interesting. I was actually talking to the Surgeon General's office because he's very interested in social isolation as well, and I was sharing the data that we had, and his team was talking, and I said, I think this is a problem that no one's talking about, which is that there's 17 million cancer survivors, 2 million people being diagnosed this year. The number of people being diagnosed is going up. Fortunately, mortality for many people is going down. Interestingly enough, if any of you follow me on LinkedIn, I just posted a couple of days ago that lung cancer mortality in non-smokers is one of the top 10 causes of lung cancer deaths in the country, which no one I talked to was like, oh yeah, literally no one knows that. I hang around with medical oncology professionals. No one knew that. And so there are these shifts that are happening. And I said, I think the problem here is that no one taught us during school or life in any other way to know how to respond to that text. I've got the text, and now what do I do? And I found that generally people are like, yeah, no. And what's interesting is that particularly, let's say you don't know how to respond to the text today, and I'm a cognitive person, so oftentimes when people are texting me, I think it's because they're trying for me to help them get an appointment or something, which I'm happy to do, right? But like, once I'm done with the like cognitive ways I can help you, or the logistical ways I can help you, then I'm like, well, how do I connect in a way that's authentic and genuine, but not sort of overbearing too much, right? But let's fast forward that, because in like lung cancer as an example, right? There's a lot of really great advancements that are happening where, I mean, I had a clinical trial at Duke, looking at non-smokers and folks who have outlived the trial, right? I mean, that's great news. But the thing is, we might be prepared of how we lean in at the 2-day mark, the 2-week mark, maybe the 2-month mark. But who knows how to lean into the 2-year mark? I'll tell you this: I've got friends and neighbors who've had cancer for a while, and they're like, "Well, it's been 6 months, so I bring it up to. I go, but then bring it up to. I bring it up to. When I see them, do I hug them and be like, hey, right? Like, how do we, right, demonstrate compassion, which takes time, and concern, which is great, and at the same time, not be overbearing. I've got a few ideas which I want to run. So one is this movement in this space around offering tangible ways to be helpful. And I know, I hope all of you guys are like, yeah, that's not a big breakthrough. Like, we already do that. I would tell you, I'm in a lot of rooms with a lot of people, and I would tell you that for a lot of people, the aha moment is when I'm like, don't offer help. Don't offer the offer for help, because very few people will take you up. This is my experience. Because when patients come to my palliative care clinic, this is oftentimes what they talk about. They're like, all these people are texting me, let me know if you need something. I'm like, great. So how many people did you text back if you need something? They're like, well, buddy. I also happen to know the CEO of Caring Bridge, the online journaling platform, very popular. She's great. And I said the same thing to Tia. I was like, hey, so when people post that, could you look to see like how often people respond with a the patient, the caregiver respondents as a follow-up? It is like almost close to zero. As the messenger, we might believe, man, I am so compassionate and concerned that I'm going to be like, hey, let me know if you need something. Guess what? Hey, my experience, personal experience, my professional experience, and what the data might show, it just doesn't resonate. What does resonate, I found, is a specific offer. And I like to do it. I'm a kind of a food guy, and most of my analogies are on food. So if you ever hear me speak again, you go, that's the guy that talks about food. So my analogy is this: hey, picking up pizza tonight from my family was going to bring one by. Do you still like pepperoni? Right? That is very different than let me know if you need something. Right? Because this requires the receiver of the message to actually sort of shoo you away. Be like, because what it's going to do is they're going to say, oh, this person legit means it, has a plan, right? And so what am I going to say? I'm going to say, actually, I have dinner plans tonight. We're good, but maybe tomorrow, right? Like you've given an invitation. It's the same amount of words in a text. It just means something completely different. The other thing I learned about is this concept of sort of organizational compassion. We were talking about like how people work in the workplace together. And we're talking about how you actually dig in when someone says like, hey, you good? And someone's like, yeah. And it's like, what do you do if you know they're not? Like, what do you do? And I was listening to the speaker. It was actually the other day. He brought a speaker to ACS to talk about organizational compassion. And I was like, well, Rachel, what do you do? And she said, well, no, you just ask again. I said, you ask it again? Yeah, you just ask again. How does that work? Well, you just go, I was just kind of noticing how you are today. Just seem a little off, that's all. You sure you're good? It's like, you can do that? And she's like, yeah, don't you do that? And I was like, I don't do that. I don't do that. Wait, people can do that? I said, well, how does that show up to the person who's being asked? Like, are you like interrogating them? I was like, no, because if someone's in a dark place and a sad place, like, hey, really black. Crap, oh shoot, I should have been doing this. So it is, so I'm not saying that the solution is complex, but it does take work. And as I mentioned, compassion just takes time. So it takes a little bit of time. And so something like that might take a little bit more time. But I'm gonna tell you, I had that aha moment even this week where I was like, oh, so it's okay to just ask again? And so Dr. Danford, the person I was talking to, she said, yeah, because they can always wave you away. They can be like, no,
I'm good. I'm telling you just like that. I'm good. But the point is asking again for honesty. And so I'm like, wow, this is the kind of thing. So just to tie back to palliative care, it's like kind of long, is palliative care as a service is one of those things that I think is table stakes as it relates to delivery healthcare. Because everything I just shared to you, just in case you think like I'm a nice guy, I think I'm a decent guy, and I have kids, so they make me nicer too, because they make me more patient, these are all skills I've learned in my training and training other people. This is not because I'm naturally a nice person. This is because I take care of people every single day where this is exactly what they need. Not because they're dying, but because they want to live, right? And so they want more and better days. And I'm in the business of more and better days. I will tell you, when I started the clinic at Duke in palliative care 15 years ago, everyone was worried that if they sent patients to me, I was going to stop the chemotherapy. Let me tell you, it's been frankly the opposite. Now I mentioned I'm agnostic, so I talked to a person. So actually, a couple months ago, 88-year-old woman with a pleural effusion. She got worked up by her primary care physician, so just fooling around a lot. Got worked up, and it turns out it was PL150. And they sent her to me to talk to her about hospice. So she walks in, and I said, let's get to know each other, blah, blah. And my typical line when I'm talking to another person is around, particularly if we're in conflict, and she and I were in conflict, we just didn't know each other, and this is a good tip for any of you. When you're in conflict with another person, you should just ask them, what are you worried about? It's awesome. It actually really is, because you're actually getting to them. You'll see really good negotiators in life, like attorneys and litigators, stuff. They do this. They're trying to get to the underlying motivation, not the overlying issue. This is how baseball players get signed by teams, because what are you worried about is, well, if my contract makes me look like a less valuable player than this other guy, then I'm not going to sign it. Oh, it's about the number relative to something else I never had an idea. So when you're doing this, it's really helpful. So I walked into the room with this 88-year-old lady, and I said, tell me about yourself. She said, well, you can read my chart. I said, no. Tell me about yourself. She said, what do you mean? I said, well, open up your phone and pull up a photo that's meaningful to you, which I think is a great way to get to know people, because people got lots of photos on their phone, and then you're like, no, just one. Well, I got my dog, I got my grandkid, I got my thing, my garden, I have this huge cucumber, blah, blah. You know what you're going to learn by just looking at the one photo they're going to show you? So here's what happens is, the moment I do that, show me a photo that's important to you. We've connected as human beings, because she's like, well, this is my dog, blah, blah, blah. I have a picture of my cat, blah, blah, here's my grandkids, here's my kids, blah, blah. So we've now connected as human beings, which means that we now are in a relational relationship, right? Relationships are either relational or transactional, just to oversimplify. Transactional is that you need something and I'm going to give it your time, which is what people think oncology oftentimes is. You are the holder of chemo. If I come and I'm nice to you and I put the wheelchair on the other side of the corner and I don't tell you about how much the side effects suck, that you're going to give me the chemo, and this is the game we're going to play. And I don't play that game. I want to help you, which is the best way to help you. Let's work on that together. So as I'm talking to this 88-year-old woman, I said, show me the picture. So she did. Show me a picture of her grandkids. And then, I think it was great. Actually. So then I said, well, when you think about the future, what are you hoping for the most? She's like, aren't we here to talk about cancer? I was like, no, I don't want to talk about you for a second. What are you hoping for the most? She tells me about her garden and these plans to go on a cruise. This is very spry, just clear. So blah, 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 blah. There's this new, Royal Caribbean has this new ship, something, Icon of the Sea, something, I don't know. She wants to go on the ship, all this kind of stuff. And I was like, oh, okay, so you seems like you are hopeful for doing all these things. What are you worried about? She goes, that people aren't going to take care of this thing that I've got going on. So you look back at the referral for her to me, 8-year-old woman, metastatic lung cancer, pleural effusion, right? So sort of synonymous with each other, and transition to hospice. And I think that's what people think that I do. So I just said, hey, here's the deal. Here's the things we can do. Here's how to support your goals. Tell me what's important to you. You want to get to a cruise? When is this cruise? Just 6 months from now. Well, to do that, we're actually going to have to probably do a little interview. What do you think? Yeah, I want to do that. And then it blew people's mind. They were like, palliative care clinics giving people immunotherapy. I was like, I'm supporting people's goals. And guess what? I'm going to do this audacious thing and ask them what they are. And then I will fit a plan to what they are. And I'm going to start with going, I don't know what your goals are, but we're both sitting here together, so we might as well talk about it. And then people are like, wow, what is that? I was like, that's called palliative care, right? And so I would look at it not just as a service, and I will end here. Look at it not just as a service, actually it's a philosophy. Is how palliative care is trying to change how healthcare is delivered. And just to, and again, if you think that like you're like, wow, I'd love to go to his clinic, I'm gonna tell you there's 6,000 people who are trained just like me across the country, advanced practice providers, nurses, social workers, chaplains, physical therapists, pharmacists, physicians, who believe what I believe, everything I just shared with you, believe what I believe, and they've trained in the way I've been trained, and they're out there doing this work. So if I can leave you with just a couple of things. One is, think about how to be an ally to another person. I know you guys know that, but we have to get this word out about how we text each other and talk to each other, and we're going to get after it. Second, let's make sure we just teach each other that palliative care is not end-of-life care. It's just as I shared with you today. It's not the majority of what I do. And third is, compassion takes time. And if that time means that your oncologist is going to take the time to talk to you about these things, wonderful. I strive that every oncologist is able to do this, and frankly has the time to do this. But if not, then we should seek out others who can be complementary to that team and do that work, and for oftentimes those are possible. Okay, thanks everyone.
Thank you, everybody. I really appreciate the opportunity to be here today. Unfortunately, Heidi couldn't make it, and I apologize for that. You know, she was supposed to be the headliner for today's discussion. I usually do the first slide and hand it off to her. So I'm going to really try to convey, you know, her spirit and her passion for this topic. So yeah, but we're going to talk about connecting with other people, collaboration, and how we leverage that to sort of promote our mission of promoting lung cancer awareness. But to be honest, in the end, I'll just say doing so just makes us feel better. It's helped with her survivorship. I'm going to give you a little bit of background information about her if you don't know. This was a picture taken of us in early October 2018. That was a period of time, probably one of the best times in our lives. You know, our lives were unfolding like a narrative that we had written, right? The storyline was going as scripted. We were masters of the universe. Our lives were going as we had planned. But as most people, you know, you have to pivot sometimes, and sometimes more so than others. And about 2 weeks later, in mid-October, Heidi was being evaluated for, you know, an ovarian cyst, and for some reason, it ended up that her gynecologist wanted to do some additional tests because the cyst was kind of complex, and he ordered a chest CT, and this was the incidental finding, which I saw first because a colleague of mine got it. And I knew enough about CAT scans to say, that's not a benign-looking lesion. And within a week, she's diagnosed with advanced stage inoperable lung cancer. And so we had to pivot quite quickly. Fortunately, due to research, and this is why research is important, a month before she started her treatment, the FDA had approved a new immunotherapy, durvalumab, and so she was started on that. But it was also a period of time I've heard a lot of people talk about isolation, feeling lonely. This is, I think, during her treatment, that's, you know, we enter the kingdom of lung cancer, kingdom of the ill, people turn that, and she, you know, immediately sensed, you know, I feel kind of lonely, I feel kind of isolated. I think at one point she used the term neglect. A couple of months later, maybe a year later, during Lung Cancer Awareness Month, she wanted to do something for lung cancer awareness. She approached the NCI Cancer Center where she got her treatment, and was noticing that on their social media posts, they were posting, you know, we light up our building pink for breast cancer. We certainly do so for other cancers. And so she thought, well, maybe they're going to do something for lung cancer. And she contacted, I don't know if it was the facilities department or marketing department. She says, hey, are you going to light the building white for lung cancer? And she said, someone told her, no, we don't do that, but and she says this, and she repeats this story, they told her that they light their parking lots with white lights and the doctors wear white coats. And that just lit her fuse. And when she blew up, she contacted me and she said, just make me a big white ribbon, and I'm going to promote Lung Cancer Awareness Month, and I'm going to broadcast that I have lung cancer. It matters. And this is the original ribbon that we made. And then she posted it on social media. And within a couple of weeks, maybe not even, other survivors started contacting her and saying, can I get a ribbon? And they started talking and sharing the same stories. And she starts to find out that there's a community out there. And those individuals started to tell her about other lung cancer advocacy organizations and national ones to connect with. And that's where we started to meet other survivors, other caregivers. Dave Bjork was here. There's others that formed an initial group. There's Chris Babb, Bonnie Earlrick, Ann Phillips, others, and getting together to sort of say, hey, yeah, let's do something about this. Started to go viral, and we ended up on the road because she was connecting with cancer directors all over the state. And one of the pictured here is Dr. Christine Lovely at Vanderbilt. We've been meeting people from industry. There's Lauren Makos from Pfizer. Small towns in Iowa wanted to build ribbons, researchers in Pennsylvania, and that it just started to balloon from there without a lot of effort, okay? And then Heidi always likes to say, well, we're global. And I was talking to Jenny Denai about this. It's like, is there some requirement to be considered international or national? Says, I don't think so. There's no specifications. She says, we got ribbons all over the place, now 34 countries, we're global. But again, the way that happened was because we just happened to meet some people. In this case, it was Caius Kim and Chad Helton at AstraZeneca. And they wanted to build ribbons, and they say, we go to these countries all the time. We have offices there. We know clients. We know patients in these countries, and we're going to get ribbons to them, which is great. And then Heidi said, we're more than just we're more than just a, sorry, I think that's there we go. We're more than just we're not an arts and crafts organization. We really want to deal with issues that are important to the lung cancer community. And that includes things like early detection, things about treatment, things about survivorship. But again, this is not something we could just do by ourselves. It was other people getting involved. In one case, we had a survivor in Kansas. She wanted to do something in Kansas. Particularly, she wanted to start doing, and she had stage 4 cancer, but she wanted to focus on lung cancer screening in rural Kansas. That was her passion. And sure enough, she was connected to the Lung Cancer Research Foundation, to the University of Kansas Medical Center, other survivors in the area. And we've seeded some funds to do a lung cancer awareness. Through her, we got connected to the Masonic Cancer Alliance. And I wrote a grant for $10,000 along with Michelle, who lives in Kansas, to try to support some local community clinics, which we were connected to by the Masonic Cancer Alliance, because they wanted to improve just cancer screenings in general, including lung cancer. And with that, we worked with them. We put up some billboards that would connect potential eligible people for screening to their nurse navigators. We provided some funds to update their IT infrastructure so that they could know the denominator, their eligibles better, and we provided some CME. And I won't go into this just out of sake of time, but the Masonic Cancer Alliance and the University of Kansas Medical Center kind of did an evaluation of the program. And, while there have been a number of factors that influence that, those little community clinics in rural Kansas went from doing about 233 lung cancer screenings, I think in 2022. A year after we all got together and worked together, that number jumped to above 600. I think there's value in that. Heidi also likes to promote, that survivors are probably the most influential people within their own cancer centers. And many of them wanted, to have, is there anything that our cancer center is going to do to celebrate, us, the survivors? And, Heidi told them, just ask, just say that's what if they're not doing it, just do it yourselves. And and you just have to connect to the right person. Engage your nurses that have been part of your team, your doctors, have them connect to your right people. And sure enough, pretty easy. A hospital in Colorado, Skyridge, had their first survivors celebration breakfast. The middle panel is Dr. Jeffrey Bellata. He's a thoracic surgeon at Kaiser Permanente, Northern California. Huge system. They never did anything for their survivors. So it was just his patients and him and a couple of other people, and then us to help them host their first. I think it was a World Lung Cancer Awareness Day in 24, and that spawned also for them to do it at another clinic. I want to say again, and most of you know this already, partnerships with industry, your pharmaceutical companies, your biotech companies, companies like Foundation Medicine, like we toured with before. I mean, it's really been a blessing. Sometimes these institutions get bad press, but I want to say the people, these companies have people in them, and most, if not all of them, want to do good things and be supportive of the communities they serve. And there's been so many events where we collaborate with them and with their support. Other advocacy organizations, LCI was one of our early supporters. When we first started, they reached out to us and they said, how we saw these ribbons, how can we help? Give us some ribbons, we'll give them to our own patients. They connected me. I wanted to get in front of primary care physicians to talk about lung cancer screening, and they said, "Oh man, we do some big event out in Asheville. We'll get you on there, get you in front of advocacy organizations and the primary care physicians, no problem." I think lung cancer centers themselves can do a lot. This is an example. This is End Lung Cancer Now was an initiative started by Dr. Nasser Hanna. He's a thoracic oncologist out at the University of Indiana. His mission, he wanted to go above and beyond just treating his patients. His mission was I'm going to end lung cancer in Indiana. That's their mission. And they know that they can't do it themselves. They say this is an all hands on deck process. We want our survivors, their caregivers, industry partners, every single organization that has a stake in lung cancer, they want them somehow to be part of this mission. And they started, now they're holding an event every year to try to promote this initiative. And I think other lung cancer centers can do this. A physician, this is Dr. Michael Gieske, he's on our board. He's a director of lung cancer screening at his own institution, among many other things. But he said, you know what, I want to get the hospitals that I've been influenced to shine big white ribbons during Lung Cancer Awareness Month to promote lung cancer awareness. And he was able to get 43 healthcare centers to do it. We showed a picture of this to a small community hospital out in Colorado, and they said, yeah, sure, we can do that as well. I'm going to let Lynn, I'm going to let you talk about that, because we've certainly, Heidi's partnered with Lynn on a number of things. Heidi says, small businesses, some of us frequent certain small businesses on a regular basis, and leverage those relationships. Most of, if not all of them, are willing to sort of say, yeah, sure, we'll do a Lung Cancer Awareness Day. Some of them will even give a percentage of their proceeds to whatever lung cancer advocacy organization or charity you want. Heidi likes to remind people that the most important thing in the journey, whether you're a caregiver or a survivor, is take care of yourself and your family first. That's the most important thing. And then if there's room, any type of advocacy is good enough. Even if the only thing you can do is put a ribbon or some other symbol of lung cancer awareness on your own front door. This is a friend of hers who just happens to decide, I'm gonna put white lights on in my house, and that's what she's doing. Also, Heidi says she's very resourceful. We were at the Washington National Mall one year, and we saw like thousands of blue ribbons on the mall promoting colon cancer awareness. And she thought, oh man, that'd be great if we could do that. Of course, we found out it cost about $150,000 just to rent the space. But she said, for $20 you can get 100 flags or these pinwheels. Go to your cancer center and sort of put them on the lawn, and you can have a good event. Proclamations, working with local city mayors. The American Lung Cancer Screening Initiative, started by Dr. Jeffrey Yang and his students, really have been really successful at this. They have a template that you can use. You show this to a local mayor. You just, and almost, every small mayor we've come across has been willing. Yeah, we'll sign it. We'll make a proclamation that November should be Lung Cancer Awareness Month. Participating in legislative advocacy. This is partnering with the GO2 Foundation every year. Many of you know they do the Voices Summit. This is Dr. Michael Gieske talking to his senators and governor out in Kentucky. Bringing the ribbon. Heidi brings the ribbon most of the time when we fly, and almost invariably there's usually someone who's willing to take a picture of the ribbon. And a couple of weeks ago, she got one of the flight attendants who happened to be someone with a history of tobacco use who qualifies for screening. She did a PSA. This flight attendant did a PSA about lung cancer screening and the eligible population. And actually, another 2 people approached Heidi to sort of say, where do I get information about lung cancer screening? I'm going to circle quickly back to the University of Colorado. This is their 5-year lung cancer 5-year survival celebration. And every year it's getting bigger and better. And this is a really important slide to Heidi, because this was a close friend, one of the original members of the White Ribbon Project, there with her holding up the ribbon. Bonnie, she's in the striped shirt with her grandkids. She was diagnosed around the same time as Heidi, same stage, same treatment. And there was really only one difference between the two of them, which never mattered, which is Bonnie had a history of tobacco use, Heidi did not, and it really didn't matter. And it's really important to Heidi to sort of say, that, the vast majority of people who qualify for lung cancer screening right now and who can be saved by it are people with a history of tobacco use, and only 5% of them are getting screened. And it's crazy, because there's 14 million people out there who qualify for lung cancer screening. And 1 to 2% of those people have lung cancer, walking around with them. Do the numbers. But this was Bonnie. Circling back, closing it out. A lot of people were instrumental in doing this, making connections at the right people at the University of Colorado. Dr. Jamie Stutz, Sharon Pine, other people. The guy who turns on the lights was instrumental. That we didn't know his name. But Heidi find out who's the guy who turned on the lights at the University of Colorado. That was the key person. It wasn't the CEO, marketing, whatever. It was the facilities managers. And they says, oh yeah, we have white lights. It's just a different switch. And so sure enough, for the past 2 years, they've been lighting the building white and allowed Heidi to put white ribbons along the trees. And there's a picture of Ann Phillips, who was the original, one of the presidents of the White Ribbon Project. She passed away, and that was one of her goals, and we were able to do that for her. Hope, this is Heidi's last scan, still doing well, but we don't take anything for granted, because this is Heidi. This is one of the reasons she does this is to just hopefully provide better outcomes for people with lung cancer. And, I used to sort of think, overall increase of survival rate of 4 months, big whoop, when I was a physician. And I feel so guilty about that, because within 4 months, we got 2 grandchildren. Those 2 little girls happened within 4 months, so a lot can happen. And I'm gonna close it out here. She had like 20 more slides for me to go through. I'm just not gonna do that for you. But we get these all the time, which is messages about people who get a ribbon. And I think one of them here is always touches me. She says, it gives me hope every day that there are people, who support those going through an often lonely journey of living with advanced cancer. So that was always her intention, is people not feeling alone.
But anyway, briefly my story, I am also an incidental finding. In January 2017, snowy day in Greensboro, we don't have very many. I thought I was having a heart attack. My daughter happened to be at the house and she said, go to the ER. So I did, my heart was fine. You know, 56, what was that, 66-year-old woman walks into the ER, you get into triage pretty fast. And they said, yes, your heart is fine, but there is a spot on your lung. No. I have no risk factors. I'm healthy, I eat well, I do what I'm supposed to do. I have lung cancer, what did I? So I had a lobectomy, I had a long surgery apparently. I was asleep, Jesse was not. And then I had chemo and radiation, and I bargained with my radiologist and said I need to be done by July 27th because my second grandson is due. And he said, okay. I went to ring the bell. I came home, I actually talked to my son and his wife, and they said, not today. I went to radiation, rang the bell, 5 o'clock in the afternoon, and it arrived. So it was kind of a, a fun day. And then I was cancer-free for 3 years, over 3 years. But we all knew I had EGFR, and EGFR doesn't necessarily go away. So I have been on Tagrisso for over 4 years. So that's my story. At the same time, my mother was living in town, and she never knew I had lung cancer. She was beyond knowing. And she died in 2019. My mother had kind of been a quiet advocate of her own, supported PFLAG early, Red and Roses, AIDS organizations. There's a reason, my brothers are both gay. And she did a lot of quiet advocacy in her own way. And I thought after she died, when there was some legacy, I could do something.
Right.
So I approached home philanthropy and said, what can we do? If I give you this gift, what can we do? And so we strategized for a while and decided that what I wanted to do was to promote awareness in lung cancer in women who are becoming a rapidly growing population, those who never used tobacco products, and create that awareness to both physicians and people at large. So I kind of had a target, primary care physicians, but we kind of figured out how to go approach it. And then of course COVID happened, so nothing happened. Because you couldn't go talk to people, you couldn't go do things. And toward the end of COVID, we decided we would develop a series of short videos. So there were information pieces that could be on social media, there were a series of 5 short ones, 4 longer ones, all with just information and all about lung cancer in women and people who never used tobacco products. So there's one on me, there's one on Luana, who was my good friend, who died in 2022. And there was one from a caregiver's perspective, of a woman taking care of her mother. All of us who had all these signs and symptoms, but we were all this. So they're out there, they're floating around. Some people, every once in a while I saw you, or every once in a while I see a snippet on TV. So they're still around. And so we finished that project and we thought, now what are we gonna do? So Cone had a support group, but it went away with COVID. And it's like, lung cancer patients aren't like breast cancer patients. We don't come out of the woodwork. We don't ask for mentoring. We don't think about, talking to other people. You don't hear about other people because you know what? You don't lose your hair, generally. You look the same. And so we revived the support group and got more people to talk about it. And now they have it, and it's growing. And we're doing more things to get people to start talking, have some support locally. I met Paula on a longevity call, an international longevity call. She lives 10 minutes from me. So, it's like, we've got to regroup. We've got to address the local need. It's great that everybody's doing things internationally, but you know what? There are a lot of us. Dr. Muhammad at Cone has 400 patients that are lung cancer patients. We haven't begun to address this. So, again, we're going back to how do we provide support, how do we educate people to think about lung cancer in kind of a different way, that it is not a terminal disease. It's turning into a chronic disease. There are lots of us living that long. And so we need to kind of change thinking. So a couple of the other things we've been doing then, as we continue to kind of look for options on what to do. One of the physicians at home, actually Dr. Eibler, who's on the LCI board, said, you know what? We could make these great white baskets, fill them with stuff, and bring them out to primary care physicians, and to EDs, and to clinics, and to residents, and talk to them about lung cancer. What we're going to do is adopt a patient, a doctor survivor there. The doctor's good when you're going to clinics because at least if you walk around Dr. Kamal, every place he goes, they know it. So you get in the door. And in it we had 2 stories, along with the treats. One was mine, and one was Paul's. And people are like, they're reading these and they're, whoa, maybe I'll start thinking differently. Mohammed and I walked into one clinic, solo practitioner, who had just met a patient of hers who had his chronic cough, no symptoms of lung cancer, and she thought, that person needs a CT. Maybe we saved the person's life, maybe we didn't, but at least she thought of it. When Paul and I met with residents, they're looking at us like, oh, look at lung cancer patients. I would never, the light bulbs are going off in their head, and these are our future doctors. That maybe we need to take a step back sometimes and reconsider the person in front of us, especially if the person in front of us is young and presenting symptoms that kind of sound like if they were 70 would be lung cancer, but this person's 35. There are a lot of 35 reports now. So I think we're ending, the last delivery is next week, I think. And I think we've been effective. We'll never know for sure. I mean, there's no way to evaluate this. But, it's one other way to try to reach people directly. So, we've also, as Pierre said, partnered with the White Ribbon Project. We did a White Ribbon bill, and it's easy. At the Hirsch Center, which for those of you who don't know, it is in Greensboro. It supports cancer patients, free activities. It's based on donations and grants. But the Cancer Advisory Board was meeting at the Hirsch Center that day, and so we made 16 ribbons. Some of them went to doctors to take back with them. Some of them went to members of the board. Some of the members of the board were totally unaware of that. Guess what? You can get lung cancer, but you never use capital. And we were like, oh, we made a difference today. And some of them started to think that maybe they need to be screened because they had used tobacco products for 20 years, although they had, were not smoking. So, you just never know who you're going to touch when you start talking to people. And so, we did that one. We were at a Grasshoppers game. And Dr. Eichhart's there on the field waving a white ribbon. It was great. And we're planning on doing it at that. We've done it last year's LCI run, we'll do it again at this year's LCI run in Greensboro. We'll have white ribbons available for people to sign and take home, or give to a loved one, or whatever. So we're looking at next year, and we're looking at the rest of this year, and what do we do next year? So we're toying with direct mailings to all of home's physicians, which is about 2,000 signs and symptoms of lung cancer. We will be meeting with at their annual staff meeting with a few survivors to talk about lung cancer and early screening. So we will end up doing that. And we're probably putting up, there's a big billboard on Wendover, which is one of our main students at Route 40, on both lung cancer awareness and early screening. Again, trying to at least raise some awareness. quite frankly, we had talked about yard signs in November, but this November is a very bad time. Yard signs, nobody would see it. So, you know, we're trying just to work in baby steps. And maybe our baby steps are. So, if anyone has suggestions to ways to partner, I mean, that's what we have to do. We have to partner because, you know, there are a lot of us. So, to get, you know, our messages across, we should work together.
Hi, I'm Liz Hynson, and I'm speaking to you as an advocate about how finding a purpose with Lung Cancer Initiative can provide meaningful connections with those involved in the organization. I'm speaking as a devoted advocate for LCI, and I have been for 17 years since the beginning of the organization. My involvement over the years has created meaningful connections to all involved, giving my life a sense of purpose and fulfillment. To understand my love, respect, and dedication to LCI, I would like to share some of my personal story with you. As a child, I grew up idolizing my mom. She represented everything I wanted to be. She was loving, caring, fun, athletic, beautiful, and the person everybody wanted to be with. Her name was Gloria, but everyone called her Glo. I, of course, called her Mom. My mom grew up in an era when so many people smoked, not knowing the dangers of smoking. She began to smoke at a young age and became completely addicted. She tried several times to quit, but was never successful. Unfortunately, my main memories of my mom as a child was with a smile on her face and a cigarette in her hand. For many years, I worried she would develop lung cancer, and sadly, one day she did. She survived a few years, but passed away in 2007, and I was completely devastated. At the same time my mom was battling lung cancer, my dear friend Sarah Saunders became quite sick, developing a cough. One more slide. That wouldn't go away. Initially, Sarah was misdiagnosed with pneumonia, as no one dreamed a 45-year-old who had never smoked would have lung cancer. When they finally figured out it was lung cancer, she was already at stage 4. Sarah survived a few years, but also passed away in 2007. I had now lost 2 very important people in my life to lung cancer in 1 year, and I was determined to find a way to fight back and raise money to fight the disease that had taken so much from me. Before Sarah died, she said to me, "We must find an organization in North Carolina that raises money specifically for lung cancer research." I told her I was not aware of any such organization in North Carolina. But shortly after our conversation, I was asked to attend a cancer symposium at UNC. And it was at this symposium that a woman stood up. She said she was there representing a lung cancer organization. And I was like, wow. What the heck? A woman from a North Carolina Lung Cancer Partnership was the name. I couldn't believe it. So after the meeting, I went right up to her and introduced myself, and I said, "How do I get involved?" She gave me a big smile, introduced herself as Sandy Oler, and as they say, the rest is history. Since the death of my mom and Sarah in 2007, I've made so many purposeful connections with LCI, helping to manage or chair fundraising events. One more picture. I've served on the Evening of Hope Gala Committee for 10 years, chaired or served the Triangle Lunch Forward Committee for 17 years, and chaired or served on the Triangle Lung Cancer Golf Classic for 15. Now, all these purposeful connections may sound like a bridge too far, but I am so proud to be on a part of each of these events that together raised over $4 million for LCI. As I got to know so many advocates through the organization, I quickly recognized that everyone was involved with one person in mind, to truly make a difference in the lives of those impacted by this disease. This is not always the case for other organizations, but for me, it was the most important reason to get involved. When I was asked to speak at the summit, as an advocate, I was a little intimidated thinking about the resumes of the people who spoke before me. I think everybody had lots of initials past their names but me. And Dr. Kamal, I think he had 6 sets of initials. So it was kind of intimidating. However, recently I listened to an LCI podcast with Paige and Dr. Neil Reddy, a Duke oncologist that serves on our board. And he made the comment saying that the support Duke receives for lung cancer is directly proportional to the amount of people who advocate for the cause. And I thought, wow, that's exactly what I've been doing for 17 years, advocating for the cause. I truly believe that with today's current treatments and awareness programs, such as screening, that both my mom and Sarah might have survived lung cancer. So while I'm very sad that they are no longer with me, I am very happy about the progress that has been made, and I know they would be too. So as you can tell by now, I'm an extremely proud advocate for LCI. And for those of you here today who are thinking of getting more involved, I know the connections you make will be meaningful and purposeful, knowing you are contributing to an organization that does so much good. And along the way, these connections will lead to friendships developed through a shared sense of accomplishment, knowing you are truly making a difference in the lives of those impacted by this lung cancer. Thank you.